And first I just want to introduce myself. My name is Joy Fritz. I have a public page on Facebook called The Untrivial Pursuit. I pursue a better understanding and truth in health research. I started my journey because of my experience in death recording, but in the mortuary industry for 6 years. My main position was doing death certificates with our electronic death registration system in California. I worked in the Los Angeles County, which is the most populated county in California, which is the most populated state. And I worked at a very busy mortuary. So I have a fair sampling of what it's like to work with physicians, with coroners, and with the local and state vital records registrars on creating death records and what that system is like. And I'll explain about COVID-19, how they're kind of changing and coaching physicians to code things and structure things on the death certificate in a way that was not typical. So when I say typical, I mean for people that typically die, right? So the elderly and those with underlying conditions have a higher mortality rate than those that are healthy. And so we typically did death certificates for people that had underlying conditions that are listed, and I'll show you in a certain part 1 of the death certificate. The last condition listed, the last cause, is called the underlying cause of death, and that is what is reported and coded into our national systems for what causes death. So that's what creates our public health beliefs that the majority of deaths are heart disease related, and then the second leading cause is cancer and kidney disease and lung disease. And that's why we believe that certain diseases are fatal and kill us, is because of the way that we structure and code our death certificates. I think there's a lot of problems with the way that we do it, even before COVID-19, but I can get into that later. A lot of the people on my page that I asked if they had questions. So I have a little stack of questions here that we'll go over, some really good questions, but I'll just go over a basic understanding of how death recording works. And then I'll share with you a quick snapshot of some of the links that I'll be putting on with this video for further reading, further education. This is nothing that I wrote. This is just things that I've read to better understand mortality statistics and what the terms are and how we code them after the death certificate's done. But I do want to talk specifically about COVID-19 because that's such a big issue right now, and because they're doing something very different with how we're coding COVID-19. It is a respiratory infection. It's a viral infection. There's a very specific vulnerable population. Not that there aren't exceptions, but we have really good data that there's vulnerable populations, and that information is important to be consistent about in our death recording protocols and not change the rule book for one virus. So let's jump in. I'll show you the memo that we're talking about. This is the National Vital Statistics System sent this out as an alert. And then they say something really interesting right here that's important. It says, will COVID-19 be the underlying cause? This term underlying cause is important. Underlying cause is the last cause listed in part 1, and that's what's reported. So if normally it's heart disease or cancer or kidney disease or chronic obstructive pulmonary disease is listed as the last line on the death certificate. So it's saying the underlying cause depends upon what and where conditions are reported on the death certificate. However, the rules for coding and selection of the underlying cause of death are expected to result in COVID-19 being the underlying cause more often than not. That is, I think, an unfair spotlighting, in my experience, of infections causing death in the elderly and immunocompromised. When there's a lot of infections we should be highlighting if we want to switch the system. And down here, they even make it super clear. Should COVID-19 be reported on the death certificate for all decedents where the disease caused or is assumed to have caused or contributed to death? I'll get into that a little bit later. Assumed to have caused or contributed to death. Certifiers should include as much detail as possible based on their knowledge of the case, medical records, laboratory testing, etc. If the decedent had other chronic conditions such as COPD or asthma, COPD is chronic obstructive pulmonary disease. It's a disease of, that has issues with our breathing. that may have also contributed. These conditions can be reported in Part 2. Part 2 is the non-important part of the death certificate. It's there for researchers to look at and kind of get a better understanding. But that was a really big flag to me, to see that we're allowing things that contributed to the death to be the underlying cause. What contributes to a death is very different than what is the underlying cause of the death, and what has always been accepted and pushed for by our vital records registrars to be recorded, which is, where did their decline in health begin? And did that have to do with most immediate kind of last day or two or last week or two complication to their health? And if they do have a health condition that would make them more susceptible to dying from something that most people don't die from, then that's the underlying cause of death. It's not the immediate cause. The infection can always be the immediate cause. So I want to be very clear. I am not advocating for COVID-19 to not be recorded on a death certificate. I am saying, yes, record COVID-19. Record it as the immediate cause of death. If it did cause health complications that were able to be diagnosed and monitored, absolutely, COVID-19 needs to be on Part 1. It just, in my opinion of how we've done death certificates up until this point in this country, the underlying cause, it's an important structural part of how we do mortality statistics. And the underlying cause needs to, well, according to vital records registrars and what they hammered into me for 6 years, the underlying cause is the decline in health. So it's what the person had for 2, 5, 10 years that began their decline in health, that put them at a point that an infection could cause their death. So the infection is the immediate cause. And let me show you here what I'm talking about so you guys can see the structure of a death certificate. Okay, so here's an example. We have cerebral hemorrhage. That can kill you by itself. You have nephritis, and then you have cirrhosis of the liver. So cirrhosis of the liver, which was diagnosed 2 years ago in this patient, would be what's considered the underlying cause of death. Even though the cerebral hemorrhage is the immediate cause. So that's the thing that happened a month ago that really led to their decline, and then they ended up passing away. But the cirrhosis of the liver put them into a compromised condition that their health declined after that. So I'll show you here something from my public page on Facebook, a snapshot of Physician's Handbook for coding death certificates. And it gives a case history of a woman, 78 years old, 2 years ago, she had had a stroke. And then she had this decline, slowly over the course of 2 years. And then she had a catheter placement. So she had, a medical device placed. And infections and complications after that for days that ended up, and the sepsis from the infection was what ended up finally causing her death. Now, what's listed at the bottom here, and they even added a line to the structured form because that's how important it is to get an understanding of the underlying condition in their mind. And it says old cerebrovascular accident. So an old cerebrovascular accident, which is a stroke, is considered the underlying cause for this person's death. So it's a stroke death. That's a stroke death. So when you see in mortality statistics stroke, people passing away from stroke, that would be what happened. They actually passed away from a urinary tract infection. That's what they died from. But their underlying health condition is what's listed in our mortality statistics. So this is an example of one of the states instructing how COVID deaths need to be recorded now. So we have, respiratory distress, we have pneumonia, and then the very last line here in Part 1 is COVID-19 for 10 days. Now, if we were to compare that to, something else, what if someone had a stroke or had chronic obstructive pulmonary disease for years and they were declining in their health? Why isn't it that we are putting down on this last line D that they had chronic obstructive pulmonary disease? To me, in my experience, that would be typical for a vital records registrar to ask me for, to send back a record and say, I see you put COVID-19, but this person was 70 years old, or this person was 60 years old. What were they on medication for? What was their chronic condition? And can you ask the doctor for that? Now, I want to be clear, if the person didn't have, if they were just super healthy, they weren't on any medications, their doctor just given them you're just doing great, right? Or they're younger and they don't have any health conditions, then the doctor would tell me that, and I would have to call the vital records registrars and say, hey, look, this doctor is saying there's literally nothing else that explains the death. It's just this. And I can imagine in that scenario them saying, okay, we needed to check, right? Because that's our standard is that the chronic health condition, if that exists, to explain why this person died from an infection that a lot of people survive. But they would, after a conversation, after kind of giving some pushback about chronic health conditions, they would then go ahead and approve it, because viruses do kill people that don't have underlying health conditions occasionally. But for the most part, you want to understand what that kind of surrounding health condition was, and that's what that final line is. They also have Part B, which is down here. You can see down here, there's a Part 2, and that is where significant conditions go, right? So if the person, has a recent fall or something like that, then maybe that would go down in Part 2. But yeah, Part 2 is really, most of the time it's not filled out, because doctors just don't worry about it, especially hospice doctors, and there's hospital doctors might put some stuff, but for the most part, Part 2 is left blank. If it is filled in, it's usually with things that don't have to do. It's a significant thing with their health, but it doesn't have to do kind of biologically with a respiratory disease causing their death, or that infection causing their death. So I hope that helps understand what Part 1 and Part 2 are for, and the significance of the last line of this memo here saying, if the decedent had other chronic conditions such as COPD or asthma that may have also contributed, these conditions can be reported in Part 2. But COPD or asthma are definitely conditions that would put you in a more vulnerable position for COVID-19. That's that. I do want to quickly explain a couple misconceptions that people have about death records and how we investigate death. And we have a typical system, what would happen from point of death until point of record being finalized. A death would occur, and if the patient had been seen under and attended by under a physician in the past 6 months, and this is California, a little bit California specific, maybe other states have, they allow 9 months or, a year or whatever. But, state by state, you can have a little bit of a difference, but the general principles are the same. So if the person was being attended by a physician, whether it be in the hospital, hospice care, nursing home, or they just got their doctor to do a checkup in the past 6 months. For California, if it's the past 6 months, then the doctor signs the death certificate. Attending physician signs the death certificate. And the exceptions to that are if you have an injury or an accident, something unnatural possibly happened, or surgeries that maybe happened in the past day and the person died within a day of the surgery, then there could be a possible legal issue with that, so a coroner might get involved. But the coroner typically doesn't get involved in most deaths. So the attending physician is the typical person to do your death certificate. There's not typically an autopsy. There's not really an intense investigation at all. In fact, physicians are usually under a little bit of a time frame by their state health and safety codes to get death, the cause of death to the mortuary. In California, it's 15 hours, within 15 hours of death, that the physician has to report. They don't normally do that, and mortuaries aren't sticklers about it, because we just need it done usually within 3 to 4 business days so that the family can move forward with services. The final remains of the disposition of the body cannot be accomplished until the death certificate is done. So it puts a lot of pressure on a quick turnaround time. So I think that is a factor in and investigation of death is that we don't have a lot of time to kind of investigate all the details of the person's medical record. Hope that the doctor has a good handle on everything, but there really isn't a close investigation at all. So the doctor needs to get us the causes, or we send a worksheet to the doctor or the hospice office or the hospital, wherever it is that we're trying to reach the doctor. We usually don't have a direct line to the doctor, so usually kind of playing a little bit of a crazy dance for a couple of days, trying to get a hold of the doctor, get him a worksheet, get her a worksheet, get them to send it back to us with causes. Then we have to hope that those causes are going to get approved, and then so we type it into the electronic death registration system. We meaning the mortuary representative or the funeral director. Types it into the electronic death registration system, submits it to the local vital registrars. Say that 10 times fast. We called them the health department, so if I slip and keep on calling it the health department. But so we would send it in to the vital registrars for approval. Sometimes they would kick it back to us and say, no, we need more information. And that would normally be, we need more information. That immediate cause does not work. That thing that happened 10 days or 15 days before death is not enough. We need to have an underlying condition of why was that person not healthy, and why did they not survive that pneumonia or that infection like most people would. So the health department would regularly kick back records if the doctor didn't give an easy underlying cause, like Alzheimer's disease or chronic kidney disease, or, obstructive pulmonary disease, or anything like that. Like, big underlying conditions were easy. Like, they just got passed all day long if they were that last line on part 1. But if they kicked it back to us, then we had to go back and forth with the doctor, get some more information. Then, if the vital records registrars approve the causes, then we have to go get the doctor to sign it. Hopefully he electronically signs it correctly. Then we have to send it back in to get it approved for final registering. And then we submit the whole record with the burial or the cremation permit, and we hopefully get that approved really quickly. But this is a crazy process that takes, between 3 to 5 business days of going back and forth between the physician and the vital records registrars, and if the coroner is involved, working with the coroner. If the coroner is involved, it normally takes longer. It takes like 1 to 2 weeks of business days to get it done, because we're on their schedule now, and they have their own caseload and they have their own schedule that is not necessarily customer based. So things can take a lot longer with coroner involvement. So everybody dreads coroner involvement usually. So the coroner isn't normally involved, but when they are, then they are. And then hopefully everything gets approved. And then the state registrars have to approve the record as well. Okay, I found this really interesting to look at. This is the provisional death counts right now for coronavirus, yesterday. So if we look here at the time frame, we have 6,930 COVID deaths. And what I found down here, the far majority of them are happening in those over 65 years old to 85. 2,000 of them, so basically a little less than a third, are happening in those over 85 years old. It's definitely hitting a population that likely has a lot of underlying conditions. And then this was interesting for me down here. It gave us a little bit more information of where these deaths are coming from. So out of the 6,930, we have healthcare setting, inpatient. So these are people that are actually getting the kind of acute care that's perhaps needed with the more serious COVID. We also don't know how many of those people were already in the hospital or were in for other conditions, and then they also had COVID. Outpatient or emergency room. So something about emergency room deaths or outpatient deaths. Emergency room deaths, at least in California, emergency room doctors, they usually don't sign death certificates. They're not required to, and They usually don't like doing it either. So it'll normally either go to a coroner if there's no attending physician, or it'll go it'll bump back to the hospice or the attending physician. And why that is because an emergency room doctor doesn't have a full picture of the person's medical condition. You know, they're working with them usually for a few hours just to kind of figure out whether they should stay and before they're either admitted or sent home. So the doctor really doesn't have a whole lot of medical record information from the physician, or, you know, necessarily accurate information on what medications they're on, or, you know, or anything if they're presenting with severe situations. So we have 421 emergency room or outpatient deaths. I don't know if that is really a good picture of whether those people had a chest scan and they're able to see and diagnose it clinically on a few different levels. And if they're emergency room, they probably haven't had the 3 days to get their test results back. So they're probably not being treated with COVID appropriate medications at that point. So did those people really have the best chance? And did they have other underlying health conditions? Is a good question. We have here healthcare setting dead on arrival. So that basically means that they died in the ambulance on the way to the hospital. So, and of course, paramedics aren't able to, you know, diagnose. At that point, you don't have a lab test. You're not getting treatment. So that, to me, is not really a solid case for saying something was COVID or whether there was other reasons of what was going on. Decedent's home. So 519, I mean, that's a good bit of the total number. And these are people at home. So I have questions about that. Why didn't they go into the hospital? If they were having acute respiratory issues, you should be going into the hospital. And then at that point, you would be getting care. So, and this isn't something that is, you know, a few hour onset and then death. So it's, you know, it's an accumulative thing where you're having, you know, a cough, fever, a few different things, a few different signs, and then more acute issues get complicated. And then, you know, hopefully you get into the hospital if you're having respiratory issues. So that we have 519 that died at home, but apparently they died of COVID by their diagnosing COVID by association, which is what something Senator Jensen talked about. If one of their contacts, one of their children had COVID and then they died, and that they're kind of conflating that and saying, well, you know, we'll just call it COVID. To me, that's not how doctors work. They don't just assume if you die of pneumonia, you're dying of whatever, you know, strain of flu that's going through the area or coronavirus that's going through the area. They don't assume that. They just put down pneumonia and then whatever chronic condition that you had, and because that's the facts that they know. And Senator Jensen kind of talks about that. So that's kind of a good chunk there is people passing away at home. And then you have hospice facility 78. Are they getting, my question here is, are they getting and same thing to seeing home. Are they getting ventilator care? Are they getting the care that in nursing home, long-term care facility? 600. From what I understand of the care that's available in nursing homes and under hospice care, you're not getting intensive, you know, respiratory techs and things like that. It's kind of comfort care. So there's, you know, nursing staff there, but there's not all the technology that a hospital has to manage an infection like this. And if you're in hospice care or a long-term nursing facility, then you usually have a chronic health condition that needs monitoring. Those deaths would always typically, on death certificates, have an underlying cause. They would have a chronic condition that led them to be in hospice care or led them to be in a nursing home. And that would be their explanation of death, no matter what infection they died from. So we're looking at about 1,600 to 1,700 deaths out of the 6,930. So that's, to me, that's a significant part of our deaths being reported that are very questionable. That did they die from COVID, or did they die because they didn't get to the hospital and get the ventilator that they needed? Did they die from COVID, or these people that are in nursing homes and hospice facilities and are at home having comfort care at home, maybe they died because they chose to not go into the hospital and get care, or an assumed case, like the document says, if it's assumed. To have about 1,700 of the total 6,900 deaths being under question because of the way that we're coding things and the way that we know that typically we structure death, then that's a significant portion of our mortality data on COVID-19 that I would question. And I would question the ones that are in the hospital too, whether they had underlying conditions and whether we would normally code that. Now, I want to speak to the difference that I saw of how hospital doctors do death certificates and how hospice doctors and attending, regular primary care physicians do death certificates. And this is just an observation, and I think it also has to do with their relationship with the patient. So as we saw here, we have a lot of these deaths being in the hospital, right? So they're inpatient at the hospital, 5,000 of them. When you have a doctor treating someone for an acute condition in the hospital, they haven't known that patient for years and years and years like a primary care physician would or a hospice physician would. They usually don't have, especially in that kind of setting, they don't have all of their medical records in front of them. We're still at a certain point where digital and electronic medical records aren't readily available for every single doctor to the hospital in good timing. So the hospitalist or whoever's treating the patient may or may not have a good picture of their underlying decline in health, whether there was one or whether their symptoms were very well managed and they were really healthy and they were active and, yes, they were on medications for some things, but they were super healthy. Hospital doctors would normally put a much more kind of small time frame of what caused death. And it's usually just what they treated the patient for, because that's what they're, in a legal mentality of what can I say that I know about this patient's health. And usually that just encompasses what did I treat them for. And so the hospital doctors will normally typically put something that's a lot shorter of a time frame. The vital records registrars will normally push back and say, yeah, but did they have any underlying health conditions? And then the doctor will have to, well, I don't know, I have to talk to the primary care physician and I'll give them a call. And it takes a few days. So sometimes they get bumped back and forth and kind of pushed to put a chronic health condition. But they'll typically, the first worksheet I would get back from them would be something that was much more just immediate, what was treated in the hospital and what went wrong that led to the death, or what kind of complicated into death. So that's my own 2 cents on why, naturally speaking, how the death certificate system would work. Even if National Vital Statistics System was not trying to coach doctors, I think that we would have a lot more COVID-19 deaths listed as the underlying cause of death, because a lot of these patients are in the hospital dying, and hospital doctors tend to put they treated them for there. So I think we would still probably have a lot of those 5,000 still there without the coaching, but I think that the other 1,700 and how we're going to be moving forward with pressuring doctors or coaching them to structure causes in a certain way is definitely problematic for being consistent and scientific in our way of doing death certificates. So let me show you some of the links that I'll include here for further reading. This is a great little editorial here from American Family Physician, and it's, kind of explaining the importance of death certificates in context of being a basis for evidence-based medicine. We have discussion of how physicians are not adequately trained for understanding what to put on a death certificate. So these are kind of the background problems of why death recording has its own problems regardless of trying to bias and highlight any one virus. And then it gives some good understanding of terminology. I'll also include the link to the Medical Examiner and Coroner's Handbook on Death Registration. Kind of gives a good understanding of how they handle injury and accidental deaths and how they decide whether the attending physician or the medical examiner coroner does it. Here's the Physician's Handbook on Medical Certification. It's the dry, boring stuff I love, but that's not your cup of tea. Totally understand. For people that do want further reading and understanding how kind of the system works from the inside, then that would be a good place to go. This is an interesting kind of appendix, and I found it by trying to see there's about 72 causes that are considered acceptable for underlying cause of death. Just 72. this is kind of for those more legally minded, understanding our regulations behind it and what is allowed and what isn't. This was interesting as far as discussing the World Health Organization and the CDC. How we do death certificates in the United States was very much standardized by the World Health Organization and the CDC working together. So it's basically international coding, and what's allowed for mortality statistics is a pretty standardized thing by the World Health Organization. The CDC works within that framework. So it was really interesting. Dr. Birx mentioned that, all these other countries are coding death in a different way. They're saying, if they have a kidney issue or a heart issue, but they had COVID, then they're not coding it right, because they're saying that the ultimate cause on the death is kidney issue or heart issue. But I mean, that's her maybe not understanding that that's an international coding standard, that we require that underlying condition for even infections that kill people at the end of their life, or in their 60s and 70s. Maybe they had 10 more years left to live, but they had an underlying condition and they got MRSA, or they got a urinary tract infection and it didn't go well and they died 10 years too early. But we don't say that they died from a urinary tract infection. We say that they died from a stroke from 2 years ago that led to their decline in health, or cancer that they were struggling with. That document goes and kind of explains that the international coding. This is really interesting. It's the slideshow from the CDC on how we're supposed to be coding and organizing death certificates. So once they receive the death certificates, then they check them for errors and they make sure that the structural lineup is accurate for the underlying cause of death. And this one would be hypertension. They would move the hypostatic pneumonia down to line B. They're just showing an example of a death certificate gone wrong. But that ultimately it would be hypertension that would be listed as the underlying cause of death. So reported underlying cause is I-10, which is the hypertension. So even though this person had pneumonia, as you can see, we're still saying that they died from hypertension, which is their underlying cause that they probably had for years and years and years. Everything's prioritized towards that underlying chronic condition. So to take out the underlying chronic condition from part 1 and to tell physicians specifically to not include that and to put it in part 2 is quite rogue of them to do, to highlight COVID-19 in that way and not allow that lots of other infections that kill the elderly get that same research spotlight that COVID-19 is getting. I mean, so if you look at things like MRSA, which is the antibiotic resistant form of staph, then you'll see that, they estimate around 20,000 people die every year from MRSA. Then we have healthcare acquired infections, which are infections that you don't have when you go in for care and you acquire. And that's 1.5 million or so infections every year, and they say about 90,000 or more end in death. And so we have these infections all the time that are complicating people that already have health conditions and causing their death earlier than if they didn't have the infection. And we don't give those the spotlight at all. We don't give those the research spotlight. So if we want to switch the way that we're doing death certificates, then that's a great conversation to have. But to biasly highlight COVID-19 just because of the financial and political skin in the game right now, with politicians guiding us and telling us how to live our lives based on the fear of death from COVID and the fear of death for others of COVID. So there's a lot of importance in a political and financial realm right now to justify and to have mortality data that shows that people are really dying from this. And I'm not saying that they're not, but people are really dying from infections all the time. So if we want to find out what infections are killing people, that's a great question to ask. And that's a great way to want to prioritize our death recording protocols. But we need to do it evenly and objectively for all infections and not highlight just one infection that gets all the media right now, that's caused much less death than many, many other infections cause every year, and let it have this spotlight on the death record that we don't allow for other infections. And it just creates an unbalanced categorization of in comparison between chronic conditions and infections and how they kill us. So want to get into those are some links I'm going to put on the thing for further reading. I mean, and there's a report from the panel. It's like a 200-page report that I loved reading, and it's just a discussion of the panel that decides what information we should be including on death certificates now. And the last time they met was like 20 years ago. They meet like every 15 to 20 years and talk about if they should add anything to a death certificate and ask any more questions, and they typically say no. So let's transition here. You guys asked questions. Some of them I can answer, some of them I can just give my opinion, but some of them I can give background information. So if this is where you got to, I'm the kind of person that I just kind of tune into videos sometimes to kind of get a basic understanding. So if this is where you're at and you want to sign off, thank you for watching. I hope it was helpful in helping you understand our system for capturing death records and the importance of COVID right now compared to how we normally and typically do things, and why that might be problematic, and a little bit of a manipulation of something that needs to be standardized and unbiased and kind of untouched. So anyways, thanks for joining us at that. But if you want to listen in on the questions, there's some really fascinating ones. The first one here is regarding medical interventions. So we know that venting, so ventilator, is kind of an extreme intervention when not necessary, so the resulting deaths from any complication of that intervention alone is skewing numbers. Medical interventions are typically not, and this is something really fascinating in general, but medical interventions are typically not investigated as contributing to death. So because the reason why you get the medical intervention is really what the doctor has the authority to attest to, because if it is because of a medical intervention or too much of a medical intervention that you died, then that would be a coroner case. And there's not a lot of incentive for a doctor to report a medical intervention that he or she authorized as being a cause of your death. But that would be, if a medical intervention did have to do with your death, then, or someone's death, then it would definitely have to be reported to the coroner's office, and they would have to do an investigation. And whether the forensic science is able to truly investigate whether a specific medication or a medication change or, you know, a catheter or a, you know, injection of some kind caused the death versus the disease that they were suffering from, or whether the underlying condition that they were suffering from, and to decipher definitively, I don't know if forensic science is there. So there's that. So medical interventions are super hard to see how much of those contributed to the death. I think maybe as we perfect the treatment more with COVID, then we're going to perhaps see the mortality rate decline, and we can see, you know, maybe what were our mistakes in treating COVID before, and what is the true mortality rate now that we have a better treatment for it. So are COVID death records an accurate enough statistic to use when making policy decisions for a nation? And further, are any disease statistics accurate enough to make government policy decisions? I've been researching disease statistics, death statistics for 2 years now, after being interested since I was doing death certificate. I was creating death statistics without really understanding or knowing it. So I've been really fascinated by this. I don't think our data capture is on many diseases is kind of up to par. I don't think our safety surveillance is up to par on medical interventions. And I just don't think that our understanding of incidence rate and our surveillance on incidence rate is consistent. It kind of ebbs and flows with medical beliefs at the time. I mean, we don't test people for like diphtheria anymore, because if you have a sore throat and you're having a problem, you know, and it's causing a pain, then you go in and get antibiotics, and antibiotics are an umbrella treatment that handle diphtheria. So you'll never have that mushroom kind of grow in your throat if you go and get antibiotics for a sore throat. So there's no reason for the doctor to test, because he doesn't see anything weird in your throat, even though it might be the diphtheria pathogen that's, you know, creating it, or another pathogen. So there's really not a lot of swabbing and testing for so many diseases. I'm really disenchanted with a lot of our disease statistics. And I mean, we're looking at COVID right now, and we've got a global shutdown and all the greatest minds and all the greatest experts putting their brains on this, and we've got chaos. I mean, this has been going on for 3 or 4 months, and everybody's head is in this, and we still can't get clear answers. I think there's probably, in my own opinion, I think that there's probably been more funding and more experts analyzing this infection than any other infectious disease historically. Like, we don't have the published literature yet, but I think how many people are doing research, are creating treatments, are analyzing the data on this. I mean, we've got so many minds on this right now and so many experts, and it's just chaos. It's you know, we're still just in a place where they're all disagreeing. And so I think that's kind of a testament to how hard it is to really get a good understanding with infectious disease data. And I think you can kind of look at some other infectious diseases and say, do we really have some good solid beliefs on those too, when we didn't even have you didn't have all the great minds on the whole globe thinking about this and analyzing it and offering their thoughts and analysis. So yeah, very interesting. So my question is, can we track in these people the severe ones, their history of vaccine injections? It seems to fall right in line with all of the research showing vaccines damaging immune systems, long-term uptick in autoimmune disorders, etc. There was a huge push for flu shots last year, maybe even just that correlation, severe COVID cases demonstrating hypoxia and received flu shot versus did not receive. Is that data possible? Not on a death certificate. It's not. We don't capture immunization history on death certificates. The closest thing that I've seen to kind of a detailed investigation of the medical record and recent blood work or things like that is on fetal death certificates. So those are different death certificates than babies born alive and everybody after that point. Fetal death certificates are from 20 weeks gestation up until birth, if they die before birth. So fetal death certificates, and you can't see it. Like if you're a parent and you lost a little one and you get your death certificate, you don't see it. You just see this top portion. But the portion that I have to do, or I had to do with the doctor, is like a 3-page document, and it's like all these questions about blood work and underlying conditions and, you know, anything that came back and testing. And so there's a lot more of an intensive investigation of the medical, all the kind of medical stuff going on around that death than there is on our death certificates for a regular death certificate. I would just love there to be where the doctor has to fill out what medications they were on, any changes in medication in the past few weeks or month or two, and brands, so we could track different brands and whether certain brands are trending. Maybe a hypertension medication, you know, as a category isn't bad, but maybe one brand is causing more problems than another brand. So if we were tracking what medications people were on when they died, or what immunizations they had recently, or what their immunization history was in general, you know, or what medical interventions they have, like the catheter issue on one of those records, that if we kind of had a better picture of what medical interventions are being used on a person, then I think researchers would be able to have a lot more information to look for safety signals, and maybe brand specific safety signals, which would be amazing. But currently we don't have that data capture possible on death certificates. There's an interesting study, maybe I'll attach it to the video as well, that they're, I think, referring to about the flu shot. So it was a study done on military personnel a few years ago, and it was basically just following them to see those that got the flu shot versus those that didn't get the flu shot, and which kinds, like there was a whole list of infections that they tracked with, and they found viral interference happening, which my understanding of that is that if you got the shot, then you were protected not just maybe against that one strain, but there was a few other, like a little umbrella of things that you're protected against, and then there was a little umbrella of things that you were more susceptible to. And coronavirus, the family of coronavirus, you're more susceptible to in this study that they did. So whether that relates with COVID-19, we won't know, because we don't, unless someone does a study. And gets all that electronic medical record information, then I don't see how they would be able to get it just from the death record information and be able to see that correlation, whether there is a correlation or not. Something that's really interesting, though, is that a little bit of a dilemma with the way that we do flu shots and how people get flu shots is that it's not always in your, I would say it's actually not likely to be in your medical record, because your typical doctor doesn't always give it to you. The way that we do flu shots, we get them at Target, and we get the $20 gift card for getting our flu shot at Target or CVS, or I had, nurses, like a little mobile nurse station set up in our lunchroom for a couple of the places that I worked at, and they would just give you your shot there. So they don't have access to your electronic medical record there. So they're not inputting that you received a flu shot. So I would say that's incredibly hard to track anyways. And I've seen that in some of the literature I've read on trying to track, flu shot correlations with miscarriage and things like that, is that unless the OB gave you your flu shot, or unless your primary care gave you your flu shot and recorded it in the electronic medical record that's shared, that the researchers have access to, then you're not going to know if the person got a flu shot or not. So it's really hard to tell between a vaccinated and unvaccinated population. The nice thing about that, the study done on the military personnel, was that they do know their medical record because they give them all their shots. So yeah, super interesting, but I think there's a general problem with tracking, especially flu shot status on a population with the way that we do flu shots. What would be your expert recommendation for changes we can lobby for? And there's another question about what would I do? What would I do if I was in charge? I would quit and stay home with my kids. No, if I was in charge of the whole mortality statistics system, I'd surround myself with experts and come up with a really cool, geeky way of capturing electronic medical records and, tracking all the safety signals or something. Maybe I'll ask Dr. Jack to head up that. But one of the things that I think that just on being part of the public that I think that we could ask for, and I think mortuaries would kind of back us, because we have to explain this all the time when people come in and they look at the death certificate and they're like, what? Why does this say Alzheimer's? They died from da-da-da-da, some kind of complicating condition. It's like, yeah, but the doctor's medical opinion is what goes on the death certificate, what they thought was the decline in health or the main cause of why things happened. And it's just a medical opinion. It's not a scientific fact. So, in your coffee mug that you get from wherever you get coffee, they have that caution hot. I think that we need kind of a dumb disclaimer on, and I guess it's not dumb because people really don't understand that unless you start researching it, that death certificates, the causes of death listed on a death certificate are not scientific fact. They are a medical opinion. And it says in the CDC's manuals for both the medical examiner coroner and for physicians, medical opinions change. Like, they're different from provider to provider, or from examiner to examiner, coroner to coroner. Medical opinions are different. So 2 different physicians are going to have 2 different opinions about maybe what led to their decline. I actually experienced this occasionally when we would get information on a death. Sometimes there would be multiple doctors listed because the family's at the house, they don't know, so they just tell us the 3 different doctors that the person went to with their phone numbers. So I just have to start from scratch and send worksheets to all these doctors. Whoever responds first is the one that, and is willing to sign the death certificate, is the one that gets it. But one time I had multiple doctors get back to me, and it actually happened a couple of times after that. But the first time I remember just being really shocked by the difference. But I realized that one was a kidney specialist, and so he wrote down that the person had chronic kidney disease, I think stage 4. And then a primary care physician sent me back a death certificate on the same death worksheet on the same person, and it was some kind of coronary artery disease for 10 years or something, and it was a really simple death certificate. And then this kidney specialist had that this person had a lot of complications and a lot of things happening. And so there's that situation where you have a person being seen by multiple doctors, and maybe the specialist says they really weren't doing well and they were in stage 4 of chronic kidney disease. So that's really what their significant situation was that led to their death most directly. Whereas a primary care physician didn't treat them for their kidney issues. And so they probably don't feel comfortable saying where the status was of that treatment and how well they were doing. So they're going to say, well, you know what? I provided them medication for coronary artery disease, so I'm going to put that on the death certificate because that's what I can honestly attest to as the fact of what I treated them for and what their decline in health was. So we have that kind of issue with the differences in medical opinion. And I think that's something that needs to be kind of hammered in, that death certificates are not, they're the only scientific fact that they are is a fact of death, that someone with this name died on this day at this time. That's the scientific fact of death. But and maybe the place that they died is a scientific fact. But the causes of death are just a medical opinion, and medical opinions change from provider to provider, or depending on who investigated death or who treated the different diseases. So if I could change anything, I would just be printing that across every death certificate, is that this is just a medical opinion. This is not a scientific fact. How do we explain away the fear when friends post articles with big scary death rate numbers? Acknowledging death is really scary in general. And I think that that's something that is a fascinating psychological phenomena right now, with this being such a global issue, with so much awareness and our whole lives being changed to basically meditate on death, because you're just stuck at home to save lives, to avoid a serious infection, and we're just having to think about our own mortality and the inevitability of it. And I think that does a lot to someone's psyche if they don't normally kind of consider that as a real option. So I think you have to know who you're talking to. So it just depends. And just, maybe offer them some of the links that I'm listing here. So you can see here, they go through by jurisdiction. So each state shows how many deaths they've had from COVID, how many deaths from all causes, and the percent of expected deaths. So the percent of expected deaths, if you go down and look at that notation too, let's see here, and look at this, like 81%, 70, North Carolina is like 25% of all expected deaths are happening right now. So look at this notation 2. It says percent of expected deaths is the number of deaths for all causes, not for COVID, but for all causes for this week in 2020 compared to the average number across the same week in 2017 to 2019. So they found the average in the last 2 or 3 years of deaths that occurred during that week, and then they compared it with how many all-cause deaths, right? So look at this. We are down by anywhere from 5% to 10 to 15 to 19 to 25. And then look at this. North Carolina, they're down by 25. Like, they're only getting 25% of the deaths that they typically get this time of year. So all-cause deaths are dramatically down. So in a weird way, you can say, yeah, I mean, COVID is a new virus. We're learning about it. We're trying to find better treatments for it. All these are good things. They're also, it's scary to think about infectious disease, and, it's something that's outside of our control in some ways. So acknowledge that that's, it's legitimate to feel the way that we're feeling right now, or to have feelings right now. But I think that having a little bit more of an eagle's eye perspective on this, and say, well, it looks like we're saving a lot more lives than even COVID deaths right now by doing what we're doing. But also just realize that over 2 million people die every year in this country. And they die from infections all the time. They die from lots of causes. They die from suicide. There's lots of things we should be taking seriously about death, not just COVID-19. There's so many things that cause death that we ought to be taking seriously and that have a lot more statistical significance than COVID-19. So if we want to talk about death and we want to talk about our fears and everything, we gotta open the conversation up to a lot more than COVID-19 and just have a little bit more of a balanced perspective on that. So those are my thoughts on that. How much higher would the death count be if we counted all the deaths that occurred inside or outside of hospitals from as far back as January that were never tested post-mortem? Coroners from around the country have been contacting health departments for testing, but they have all been denied because they are prioritizing for the living, in quotes, because of mass shortages. My own family lost 2 relatives this week in a nursing home that almost certainly had it, but because they died outside a hospital, they will not get any tests and won't be included in the official counts. So real quick on that, according to that memo, they will be included on official counts, or they can be, even without testing. Assumed cases can be. Without lab tests, it was very clear on that memo that the doctor can, if they feel that it was caused by COVID-19, they are allowed, according to that memo, to do that, to be included in official counts. And we saw in the charts that there are people that died at home, that died in nursing homes and hospice and long-term care facilities, and they're part of the count as well. So it's not just hospital deaths that they're tracking. There's no question this virus was in the USA long before, and the first official death, so that leaves hundreds or even thousands never tested or counted before then. It's sad that testing shortages won't be able to give us an accurate count, and that is likely exponentially higher than the lowball number they are showing us. The question I have is, how much higher do you think the numbers are? I think that's a really fair question because, when we talk about antibody testing, and there's a lot of discussion of how we want antibody testing so that we can find out if we say that it has gone through the population, but we weren't aware of it, and we weren't testing during that time, but deaths statistically were still occurring. How many deaths happened before that aren't part of the count? Now, I don't think that justifies manipulating death recording protocols, because there are ways, once you are tracking a disease for a certain period of time, and then you know how long it was in the population before, you can mathematically kind of model how long based on how many flights from Wuhan were coming into your area, or travel or whatever. Scientists that's what they're doing, right? They're creating these models to say how much it was around. So once we are tracking it for another few months, I think, or to the end of the year, we'll get a much better picture of how fast it spreads, things like that. And I think we'll be able to fill in that piece of the puzzle going backwards from where we are today back to December, and say, when was the actual curve, right? How many people actually were dying? And maybe we're only tracking the bottom of the curve right now, and it already went through. So there's a lot of interesting conversations around that. But I think that's fair to say there likely were more deaths than perhaps are being counted right now. But I don't think that we should misrecord current deaths, because every person deserves a death record that is accurate according to our current protocols, without the manipulation of, this memo, and consistent with our mortality statistics. And we can do all that mathematical modeling eventually and kind of get a better understanding. I don't think we can do it right now because we don't really have a good sense of the curve. We don't have good antibody testing going out to everybody. So I think we'll be able to do that, though. I think we'll be able to get a better sense of what the actual real numbers were, and maybe look at hospital records, and hospitals can report kind of unusual pneumonia cases. I think we're going to get there where we're going to maybe kind of count some deaths going backwards based off of some statistical modeling too. Is this similar in other countries? I'm in the UK, so curious if this happens here too, in other Western countries. So Dr. Birx said that we're doing things differently here in the United States compared to other countries. The other countries are still calling these, when people die with COVID, being tested positive for COVID or having the symptoms, and they die because if they had a kidney issue or a heart issue, it's being recorded as a kidney issue or heart issue. It doesn't mean that COVID wasn't on the death certificate. She's referring to that last line that refers to the underlying cause of death. So that was our international model before. That's how we did deaths before and recorded deaths before. So she's saying we're taking a more liberal view here in the United States But as far as I know, they haven't changed international coding protocols for this at all. If they are counting anyone who died with COVID-19 as a death by COVID-19, should we suspect that there has been similar recording issues with other illnesses, for example, flu? So no, this is really a standout directive from the National Vital Statistics system. So, but I will say this, that flu is also a very politically and public health, which public health and politics are constantly kind of interacting. So with the push for flu shots, this is my own opinion, with the push for flu shots and it being this kind of seasonal thing that we give a lot of media attention to, a lot of awareness in the medical community, then that's going to influence a medical opinion. Because again, these are not scientific facts. These are medical opinions. And medical opinions are influenced by the information that they're receiving and their kind of educational environment. So if they're getting a lot of notifications about the flu season and being aware of the flu season, and then we're doing more testing for people that have flu-like symptoms, what kind of flu they have, and then they test positive for influenza, then yeah, a hospital doctor could put influenza as the cause of death, but it's not being standardized like this memo is doing for COVID-19. So it's not saying that anybody that tests positive for flu needs to have influenza listed as their last line on part 1. That's not how we do influenza deaths. Otherwise, we probably have way more influenza deaths as the underlying cause. So it's not this coached kind of standardized protocol for influenza deaths. It's still up to the medical professional's opinion, which is, I think, if that's what we have for everything else, that's what we should have for this. Is if this is the medical, if it's supposed to be based off the medical opinion of the provider, then let it be the medical opinion of the provider. If they have the opinion that it was COVID-19 that killed this person and no other underlying conditions, they're allowed to put that. That's their medical opinion. But to me, you shouldn't be coaching someone's medical opinion. You should allow them to look at the full medical record of each individual patient and decide really what was the decline in health and what were the factors and how important those factors were and how they want to structure that. So, but flu deaths are not recorded similarly in the sense of coached and directed like this, but pneumonia and flu are technically allowed as underlying causes. Yeah, the health department or the vital records registrars that I worked with would still push back. They would still ask for a chronic health condition, but ultimately if the doctor pushed back and said, no, this is what killed them, this is what I'm saying, then the vital records registrars would allow them to assign to that. So, but it definitely explains why we have much less numbers with flu. What are the main long-term repercussions of such false recording that we should be aware of? What are the main long-term repercussions of doing anything unscientifically and then labeling it as science? I think that the long-term repercussions are already here of us thinking of mortality statistics as these scientific facts. And then we're trying to say they're scientific facts, which there's a lot of problems with saying that because they're just a medical opinion. And now we're taking this freedom of medical opinion that's already kind of manipulated a little bit by the vital records registrars and depending on their own preferences and the international coding things that have been decided upon. Long-term consequences is that we're going to be comparing COVID-19 to heart disease and kidney disease and all these other diseases as if this is a massively fatal, main cause of death. And then all these other infections that kill people are not getting the attention that they deserve. And I think that's really the problem here, is that we're putting the spotlight on COVID-19 when already global research is exploding for this disease. I mean, private sector and public sector, everybody is doing so much to study this disease because it's created a global shutdown. There's going to be interest in solutions and research on this for so long. I mean, this is changing our world right now. So there's no reason to create this highlight on mortality statistics for this disease. People are already going to be putting tons of money into researching this. But what it does on what's supposed to be an unbiased, standardized protocol of capturing death records is it's pretending as if these people that have died from heart disease and cancer and kidney disease and lung disease, that these people didn't die from final infections, that maybe they would have survived if we put more public funding into figuring those out. Or maybe these people died because there was too many medical interventions going on with them, or the wrong type, or the wrong brand, or something like that. And we don't equally investigate their complicating factors for people with underlying conditions. But we'll research COVID-19 all day long because now it's getting this huge amount of attention. So I think that that's the main issue, is that it's getting undue attention that it already has. It already has enough attention to keep research on COVID-19 funded for decades. So that if we want to change our death recording protocols to really capture those complicating factors that end life, a few months or a few years earlier for people with underlying conditions, then let's change the protocols. But don't just change it just for COVID-19. What are the main reasons for and who benefits from recording the deaths in this way to seem more inflated? I think I already covered this a little bit, but I think that politicians and our public health leaders, they shut down the globe for this. So their ego is on the line and their reputation is on the line, and their models, their whole professional, everything that they work for is on the line. And they have a very potentially angry mob of people if they got it wrong. So I think that there is a very human reason why mortality data would be a prime victim of manipulation at this point. Okay, pushback I'm getting is saying that even if they would have died from something else later, COVID sped up the process and they died earlier than they could have otherwise. That's true of so many infections that the immunocompromised and the elderly die of. They could have lived for years more if one thing or another hadn't happened. But their underlying health condition puts them in a vulnerable position for so many things to possibly go wrong. So any one of those things. And again, it's just the unfair spotlight that COVID-19 is getting, when plenty of times it's a final infection that kills people with underlying conditions. But yeah, if you look at some of the examples in some of these links that I'm going to leave, you'll see that argument can be made for most death certificates. That, well, this person had Alzheimer's, they could have lived for another 5 years. This person had coronary artery disease for 10 years. They could have lived for another 10 years. People live with coronary artery disease for 20 years all the time. So that argument can be made for so many death records today, and the way that we do death records constantly is that, but the person could have lived. Yes, they could, absolutely. But then you're talking about only wanting the immediate cause of death on the death certificate, and that's not how death recording works currently. If you only want to know the immediate cause, the thing that happened 2 days or 1 week before death, and that's the only cause that you want listed, the whole international coding system of how we do death certificates would have to change. Documentation required for a death certificate? Nope. In the case of a death listed as a cause by coronavirus, does the actual test used get listed? Nope. If no test used, is it documented as diagnosis by symptoms? Nope. In infections, it's just the doctors in charge of, if like the death record got taken to court, then the doctor would have to provide supportive documents for why he diagnosed the way that he did or had that medical opinion. So no, there's no, unless it's a coroner's case, and then the coroner gets like a Form 18 packet from the hospital, which is just this fat packet of the medical record and, a bunch of information for the coroner so that the coroner can have a better understanding. But no, I just send a worksheet with a mortuary letterhead on it, and the doctor sends me back the causes, and I enter them into the electronic death registration system, and I don't need to see any proof of why the doctor diagnosed the way that he did, and he doesn't need to write down why he diagnosed. Are there other illnesses or diagnoses that the medical community has assumed it was the cause and it could be put as a cause of death? It's looked down upon. There's exceptions, and normally it's if the doctor's really not sure and he doesn't want to do the death certificate and the coroner doesn't want to take the case, the coroner doctor and the attending doctor will call and talk to each other, and the coroner doctor will basically say, you're allowed to put probable. If you don't know why they died, you could put probable coronary artery disease or probable bowel valve perforation or something like that. They kind of coach each other in that situation if the doctor's not comfortable, but it's considered a rarity. Dying with versus dying from. Dying with versus dying from is the difference of part 1 and part 2. So you can die with, you're on 10 different medications, right? For 5 different diseases that you have. But the reason that you died was maybe a gastro issue, and maybe that has to do more with your kidney disease. And so that would go up into part 1, because that is the more kind of mechanistic connection there. And then you could have heart disease and all these other things that you are on medication for, and you die with those conditions, right? So you have those conditions, but that doesn't explain why you died. So dying from would be more causal, and dying with would be more contributory. And I think that's one of the big things, is that they're really swapping those, and they're allowing for a really liberal interpretation of that, to the point that they're actually saying, if COVID just contributes, it should go into the cause. And if it, even if the things that would have been considered to cause death before, should be listed in contributing. Okay, this one's important. I'm a nurse working in New York. I have some insight on this issue that might help you to understand it. There is a 30% false negative rate. All patients have the same trends in labs, chest x-ray, looks like same for all, even if negative test. Anyone who has underlying conditions, those conditions become extremely exacerbated. There is a cardiac component to it that makes people with healthy hearts go into arrhythmia, and those with heart conditions to become unstable. Viral encephalopathy is seen in most. If you have diabetes, you seem to have it worse. COVID should be listed as the cause of death, even though you don't use virus names as a cause, because it actually makes all underlying health conditions unmanageable. I love your work, I support it, but I'm on the front lines, and 90% of patients in my hospital have it. I have been a nurse for a while, and I've never seen anything like this. So I absolutely respect our medical community, and debating and discussing data capture and how that affects accuracy of our public health beliefs is kind of a bigger conversation than just, is this virus real? Are we taking it seriously? Are people dying from it? Absolutely. The virus is real. People are really dying from it. It's very serious. And the medical community is working their butts off for COVID patients that they have. And it is something that they haven't seen before. So there are things about it that are very difficult. It's very hard to treat because we don't have a good handle on treatment. I acknowledge that. I acknowledge that it is something that you in the medical community have not really seen before and had to deal with. That there are, and that there are things, that underlying conditions that make your prognosis worse. So your ability to actually get through the virus is worse. And she's saying that. She's saying that, if you have heart conditions, you become unstable, not just have arrhythmia. In healthy people, it causes arrhythmia, but in people with heart conditions, like they're unstable, it's worse, right? And that, diabetes, you have it worse. So these underlying conditions do contribute in a causal way to the virus's ability to kill you or not, in a statistically significant manner. And we've seen that globally. So the statistics that we're capturing in death recording need to be able to reflect that, if that's the way that we capture death certificates, which is what we do. We do capture underlying health conditions. And this virus does cause things to get worse for these people, right, that have underlying health conditions. And lots of viruses do the same thing. I think that there is a real need for the medical community to bring awareness to, this is very real. This does have a real risk of death. And I acknowledge that it does have a real risk of death. And we need to statistically understand, in the standardized way that we capture final infections, how significant is that compared to all the other infections that the elderly die from. Now, maybe as a medical provider, you're not as worried when someone comes in with a urinary tract infection and is 90 years old, because you know how to handle a urinary tract infection. You have standards of care for that. you know, you're just going to do the best that you can, and you know you're going to give them the best treatment that you have available for handling a urinary tract infection or MRSA, a MRSA blood infection. And so you have a comfortability with and you don't have to put on tons of protective gear when someone has a urinary tract infection. So I think there's just psychology behind it too. You have to gear up and protect yourself. You have something that you don't have great treatments for. I completely believe the medical community that this is serious, that they're not able to treat effectively all the time, and that it's actually killing people. Absolutely. That doesn't change that we have a system of recording death that has a place for tracking final infections. And that's where this belongs. But that a medical provider has the freedom to make the decision that if their diabetes was well managed and they were doing fine and they were active and they were just, everything was doing well, they had underlying conditions, but everything was well managed, and this COVID-19 just came out of left field and hit them, and they passed away from it, and the medical provider thinks that that is the main cause of death, they absolutely have the freedom with our previous system of doing things to put that as the underlying cause of death. But if the medical provider feels that this person was, 70, 80 years old and at a serious decline in health, where really most infections would have knocked them out and gotten them into the hospital, and they probably wouldn't have had a good prognosis, then putting their underlying condition with COVID-19 above it and the underlying condition below in part 1 would be the accurate way of doing the death certificate as we've done death certificates. And I just think that there needs to be that freedom still for medical providers to have that medical opinion and to have an individualized medical opinion for each patient based off of their disease course and their underlying conditions. What are the legal requirements to putting a specific cause of death on a death certificate? For example, I know you write SIDS for vaccine-involved deaths. Is this technically legal? Also, I was told that there is a cause of death and a secondary cause listed in a death certificate. Is that true? So there is a cause of death in part 1, the underlying cause of death. We've talked about this. And the secondary cause, all the causes go in part 1, and then the significant conditions go in part 2. Regarding SIDS deaths, this is something I've looked into pretty extensively, and I think it's very heartbreaking that we don't have more research and public health attention on investigating what's going on with SIDS deaths. If you look at that medical examiner coroner manual that I'm linking, you'll see the way that they discuss how to diagnose that, and it's that they basically say that if you rule out everything, including medical history, and you still don't know why the infant died, then you say SIDS. It should be unknown cause. We should be admitting humbly that we don't know why these children are dying and not pretending it's a syndrome and not calling it a syndrome as if that's an actual diagnosis, and that we know something. We don't know something when we say it's a syndrome. We don't know what it was that killed the child, and that's not fair to try and rebrand that as a medical syndrome. The medical syndrome of not knowing. That's what SIDS is. And we need to do a lot better research on what causes SIDS. I mean, thousands of babies are dying every year, and it's one of the leading causes of death for infants, perfectly healthy infants. And so why aren't we researching that? Okay, I think that's it. Thank you guys so much for your questions, and I hope I was able to kind of give a better picture of how deaths are recorded and what are some of the complicating issues in the system. I hope you've enjoyed this. I hope it's been helpful and informative. And again, I have a public page called The Untrivial Pursuit. It's basically just my journey reading health research, thinking about it, analyzing it, and offering my thoughts. Any questions, feel free to leave comments. Feel free to share this if this was something helpful for you in understanding death data capture, the kind of the lack of science that's there, and the need for us to kind of adjust our trust in any public health beliefs that are put out there and think a little bit more critically about where the data comes from and how it's reported and the kind of fallibility of those public health beliefs and the data capture that we rely on for them. So hope you've enjoyed this, and take care. God bless.